in context, it was building on a number of operational research and investigations done by both OPHID and UNICEF on home delivery and also on uptake of maternal health among different populations in Zimbabwe. So we all know that non-institutional delivery is linked to increased risk of maternal and infant morbidity and mortality, as well as increased risk of transmission of mother to child of HIV vertical transmission. Previous work, including that done by Dr. Magurinyanga, has shown that membership to the Apostolic faith is a predictor of non-use of maternal health services. And that in Zimbabwe, the previous ZDHS indicated that up to 38% of women of childbearing age identified as belonging to the Apostolic faith. Now we know that some apostolic groups, this is not to indicate a generalizable brush on all members of the faith, have developed their own healthcare systems. Within this system, they receive different names: apostolic midwives, apostolic traditional birth attendants, and we will refer to them as ATVAs in this study. Previous to now, little was known about the practices or beliefs of this specific group, or documented. So our aim for this research was to explore the institutional arrangements, knowledge and practices, and accountability of ATVAs. The objectives were to explore the institutional arrangements, to identify the processes and procedures used by ATVAs in providing care to women during pregnancy, at the time of labor, and postpartum, and to identify and offer insight into the existing needs and assets, recognizing that this wasn't a piece of research that was meant to demonize or uncover, but also that there are cultural assets and strengths, and then also to provide clear recommendations for further collaboration. So, to put it in context, this was an exploratory qualitative study that was conducted in Mashonaland Central, which at the time, and still does, I think, have the highest rate of non-institutional birth in Zimbabwe. And the study was conducted between March and December 2013. The theoretical underpinnings embedded within this qualitative research primarily was that of harm reduction. And for those who are unfamiliar with harm reduction is a theory that's often used amongst populations who, for whatever reason, might be unwilling to change practices that may be harmful to their health. It's often a theory equated with, for example, HIV transmission with injecting drug users, that you provide interventions to reduce harm rather than to change the behaviors. And then appreciative inquiry as an exploratory piece. Often in exploratory qualitative research, the process of undertaking the research will yield as much lessons as the findings themselves. So there were 4 distinct data collection tools used for this piece of research. One was semi-structured interviews in which apostolic birth attendants were interviewed by research enumerators, 2 research enumerators, one who was a member of the apostolic faith herself, and were both qualified midwives. This included also storytelling vignettes of complications that could occur during childbirth, during pregnancy, and during postpartum periods. And then also, because enumerators stayed with midwives or apostolic birth attendants during the period of field work themselves, lived with them for up to 5 days at a time, there was also non-participant observation to understand how these women go about their practice and their daily lives. And then finally, recognizing the importance of leadership within the apostolic faith. Key informant interviews were conducted with 2 mid-level church leaders from both the Masoe and Merengue groups. So just to put things in context of what happened during field work, this is an example of the storytelling vignettes that were used to explore what happens in the event of complications. So this was the story that was provided. Fungai is breastfeeding her new baby who was born 5 hours ago. When Fungai stands up, blood and clots run down her legs onto the ground, and her clothes are very soaked with blood. So those involved in healthcare will recognize this as a potential postpartum hemorrhage. So to understand what the response is by apostolic traditional birth attendants, you see, can you think of a time where you may have experienced this? And then there are subsequent questions to understand What are the signs? What was the action taken? What was the outcome? And what is the underlying belief about the cause of this situation? So the analysis of the qualitative data was done using thematic content analysis. I think it's well recognized in Zimbabwe from Dr. Bryan's research and from others that there are two distinct groups, both the Mazoe and Marenge, and so thematic content analysis approached each group separately, and then we also looked for within and between group themes and trends. And the thematic content analysis was done through institutional arrangements, the practices of ATBAs, willingness to collaborate with the formal health system, and payments received for their services. So I'm going to start a bit at the beginning with the limitations, just so we can frame the results that I'll present to you now. As an exploratory qualitative research study, this is really the first step in understanding what the practices of this group are. It's not meant to be generalizable to all apostolic groups in every community in Zimbabwe, and it utilized a very small sample with a case study approach. And so really, I think the value is in deriving a first step in understanding what this group is, what their practices and beliefs are, and then building on that. So moving into our findings, first, within the research procedures, to sample these women themselves involved some valuable lessons. So for the procedures, we went to the district health authorities and each district in Mashonaland Central, and we asked them, were there any known apostolic midwives acting or apostolic traditional birth attendants in their area? And then with the help of OCHA, we actually provided large-scale maps in which we were able to map out the different midwives under confidentiality circumstances. And what this exercise showed is that at district level, very little was actually known about the location and practices of midwives. And that once we got onto site with midwives and rapport and trust was gained, that there was actually snowballing that occurred where they were identifying other midwives or other traditional birth attendants in their area, so that many more existed than were known at district level. And that finally, a main lesson was that the greater the collaboration the district reported, mutual collaboration engagement with the apostolic community, the more known ATBAs there were. So for example, in Bindura, compared to other provinces, they were able to identify 14 ATBAs in comparison with other districts. So starting off with the belief systems, and I think this is of interest to a lot of people, and it has been reported in more depth by others, so I won't go too far into it. But cross-cutting belief systems between both groups were that the Holy Spirit is the guiding force in faith healing, that witchcraft or evil spirits were largely responsible for ill health, and that visions of who needed practice and what the solution or care that should be provided were guided by the Holy Spirit. And that prayer and holy water in particular were used for healing, faith healing. Cleansing in particular is an underlying belief that was expressed by a lot of ATBAs in terms as a route to good health. And that spiritual health, and I think this is really important and how we frame what we're looking at throughout the rest of this presentation, was seen as primary to physical health. So spiritual health was very, very important to overall health. So for an example of the Holy Spirit as guiding force, a couple of quotes. We have spiritual guidance. The Holy Spirit shows us the problems and provides us the solutions to the problems. And this is a spiritual thing. If you believe in it, if you believe in something, it happens. It's faith-based. So now looking at the institutional arrangements of the groups. We found both similarities and difference between the groups in terms of their institutional arrangements and structures with leadership. We found both groups, ATBAs, were operating out of their own homes. We found that ATBAs were primarily considered healers within the structure of apostolic communities, and that appointment was made by the Holy Spirit. No formal medical training was reported as required to become an ATBA, and that between ATBAs, information was shared about practices. But there are also differences. Among the Marenge ATBAs, hierarchical leadership structures were described. No formal training was reported by any of the ATBAs, and no use of medication or referrals was reported. Versus the Masoe group, which was a more decentralized leadership structure, and most importantly, there was a more pluralistic utilization of health services, which included both services by ATBAs and referral to biomedical health services or clinics. There is a cascade of care within the Apostolic community that approximates that of the biomedical health system, where care is provided during pregnancy, labor and delivery, and then after delivery through postnatal care. Of course, there are some essential differences, notably that there was a lack of functioning emergency referral systems amongst the Apostolic care providers, and that also there were considerable infection control limitations. In terms of managing complications, in terms of the diagnosis, cause, and treatment of complications, again, we have similarities. Scans were done over the abdomen with the hands by the Apostolic ATBA. There were visions that resulted in the care. In terms of the cause, similarities were the evil spirits and witchcraft, but that Masoe ATBAs also acknowledged that there were some biological causes. And in fact, some Masoe ATBAs reported looking at clients' ANC cards to note if there were any complications in the pregnancy before they provided treatment. There was a lack of standard precautions in cleanliness. There was a limited knowledge of infection control. Internal exams were done with bare hands, and that, for example, the same bowl of water was used for multiple procedures. And finally, where standard precaution equipment was available, it wasn't observed to be sterile. The good news, there's lots of good news here, that there's a great willingness to collaborate by both Masoe and Merengue ATBAs that were involved in the study. In terms of shared preferences, there's shared preference to meet within the community rather than at clinic site for discussions about collaborations. There was an indication of acceptance of infection control material if it was provided on the terms of the ATBAs. And a willingness to receive training and information, again, within acceptable boundaries. There are many assets and also needs amongst the ATBAs. Assets, obviously, that we would have noticed by the information that was provided now is that they provide acceptable holistic care that's both spiritual and perceived to be physical in nature, that there's welcome dialogue, and there are positive practices that exist. One of the key ones is that they provide care to vulnerable women. Some of these women that access care through ATBAs are the most vulnerable in their communities, and that ATBAs actually give their own resources to help these women. One quote, "Most do not have a blanket to cover themselves in the homes that they come from, so they don't even have one to bring with them. They don't have one where they came from. And so when she comes to maternity, you'll take your children's blankets because you cannot leave her with nothing." So I think this is an example of the community-mindedness of ATBAs to help other women in their communities. So moving quickly to recommendations, I'll frame these in terms of short game, medium game, and long game. Short game, 100% harm reduction. We need to reduce harm with known, evidence-based, feasible, low-cost interventions. Easy things such as information about maintaining the warm chain, promotion of exclusive breastfeeding, clean delivery and cord care, and basic infection control through standard precautions. Mid-game, revisiting models of referral, advocacy, and collaboration. There was expressed willingness to collaborate with the biomedical health system by all ATBAs in some capacity. So strengthening this collaboration should act to strengthen the community-based referral networks and identify positive practice that exists. And also to improve apostolic friendliness of healthcare worker attitudes. And finally, in long term, is acceptable behavior change, which should necessarily involve high-level engagement between apostolic leaders and Ministry of Health and Child Care leadership, and that underline rights-based approaches that aim to strengthen culture and people rather than changing belief systems. And so part of this will be to document and share examples of positive deviance where the systems are working and capitalizing on communication for development and change.